Slide share the people.
Okay, can we begin?
Yes, ma'am. You can begin now.
Yeah.
You are like.
Very good afternoon, everyone. So this is our third feature live on the occasion of Birth Defects Awareness Month. So myself, Dr. Aparna, Clinical Director Neonatology from KIMS Cuddles, Kundapur, and we are joined by Dr. Sudeep Verma, Senior Consultant Pediatric Cardiologist, and we also have with us Dr. Sujana, our Clinical Associate in Neonatology, who is going to be taking part in this interaction today. So we all know, we have been discussing this month that birth defects are going to contribute to an increasing proportion of neonatal deaths as well as morbidity, and indirectly to the under 5 or child mortality and morbidity as well, with more and more advances in neonatal ICU, with more and more survival with other common diseases like prematurity, asphyxia, and infections. We are going to see an increasing proportion contribution due to birth defects. And today we are going to discuss about special group of birth defects, which are the congenital cardiac defects. So there are babies who are diagnosed with heart problems right from before birth, or sometimes immediately or few days to weeks after birth. This group of problems contributes to close to, almost 1% of children or babies are diagnosed to have some form of structural problem in the heart. So this is one of the major groups of birth defects. So to discuss this, we have some important questions, and I'll request Dr. Sujana to begin with these questions. Good afternoon, everyone.
Just to continue, thanks, Aparna. Thanks, Aparna, for introducing and to tell the preface for the congenital heart disease. As you already told, 1% of the live births are having congenital heart disease, which increase in certain situations like diabetes or any maternal factors. So it's very imperative and very important to know which diseases are more prone for getting repaired, cured, or which are not amenable completely for the repair. So once you know that in the peripartum, like before in pre-pregnancy or after that, then the management and the outcome we can clearly tell the parents, and the outcome will be decided. So thanks a lot. Now Aparna has told you all, now the Sujna and all will discuss, and she asks questions so that we can answer what are the important questions regarding the congenital heart disease screening, management, and diagnosing them. So go ahead with Aparna. Thanks a lot for that.
Sir, what is the congenital heart diseases, and when we have to suspect them?
See, this is one of the any heart disease which is present from birth is congenital. Congenital is present from birth. Something it's now with the advent of the fetal echo and the TIFA, these diseases can be detected before birth also. So as you already know, or we can tell, the heart structure will be completely formed by the 10 to 12 weeks of pregnancy. That means even after first trimester. So the exact age by which we can detect to have congenital heart disease or congenital heart defect is by 18 to 22 weeks during TIFA or the fetal echo, where we can tell the heart disease is there. So in general, the congenital means from birth, but you can be detected at before during the TIFA or the fetal echo evaluation between 18 to 22 weeks. So congenital means from birth, heart defects pertaining to the heart, and the defects which are present in the heart from the birth or during the development of the heart.
So just one thing I would also want to add is not all the congenital heart defects may present with the signs and symptoms immediately after birth. For example, babies who may have a large hole called as ventricular septal defect, and another type of hole which is called atrial septal defect. These may be present, they would be present right from birth, but the babies may manifest with the signs and symptoms a little later. So it is not that congenital heart defects, all of them would manifest with signs and symptoms soon after birth. For example, a typical large...
Okay, well, carry on. I thought you finished, please.
A large VSD would usually present with symptoms by something like 3 weeks, 4 weeks of birth. Sometimes it can be prolonged to as much as 6 weeks after birth. whereas a very small hole, a small VSD, it might be absolutely silent for many months together. Likewise, atrial septal defect may present for the first time in early childhood or even adolescence. So, although these may be present from birth, some of these conditions can manifest a little later. Whereas there are other group of congenital heart defects which may present immediately after birth. So they will you cannot miss them right from the time the baby is born. The more critical ones, like for example, there is a condition called hypoplastic left heart syndrome. There is another condition called coarctation of aorta, where there is a major block in the major blood vessel that carries good blood to the rest of the body. So all these are likely to present in the baby soon after birth. Dr. Sudeep, would you like to add?
Correctly, you said there are two defects, like one which can be present later and which can be presented very early, like cyanosis. What she told to where the heart will be failed, like the block and the hypoplastic left heart. There's somewhere there is a blue color from the birth, which is, if it's not because of the respiratory or lung cause, then it's usually you have to suspect the heart disease. Those who are presented from the cyanosis in blue color from the birth, they are the more which we have to treat early. Or second thing, which can present in a severe form like hypoplastic, where the one of the chamber is small, or any wall block like wall of the aorta or wall of the pulmonary stenosis, or the coarctation where the tube which is supplying the heart. If these are getting blocked, then you have to present early, and they present early and you have to treat it early. So correctly said, all congenital heart disease may be detected, but it may not affect the newborn or infant. In all cases, some can be detected very late, some can be detected early, but it's imperative to diagnose so that you can observe closely. It should not be like that it's a serious disease, but we waited for long and the child got deteriorated. So you have to detect first, and then you have to follow for the either the group we have to wait and watch, or with the group where we have to do the as early as intervention, or with wait and watch approach, when correct time will come, we have to treat that. So as you rightly said, Aparna, that is the two groups which is very important to decide, and the outcome also dependent on that. So very rightly said.
So which mother has to be screened for the congenital heart disease, and what are the indications for the fetal echo?
See, I already told there are three indications mostly for the fetal echo. One, when the mother has got any risk factor. What are the risk factor in the mother? So risk factor in the mother, when mother itself has a congenital heart disease, got operated and she's getting pregnant, so the chance of baby having heart disease is more. Any of the family member affected having heart disease is more. Third thing, when mother is having some issues like diabetes, when the IVF pregnancy, the chances of getting congenital heart disease is more. So these are the two more important. And third, when any sibling got operated, now you are getting, now the you are planned second, and during second conception, during second pregnancy. These are the three. So three important features: one of any of the family member, sibling, mother, father, any got affected heart disease. Second thing, when there is a risk factor, or when there is a high risk pregnancy like elderly pregnancy, okay, like mother on antipsychotic drugs, or mother on the drug, or mother is having the diabetes mellitus. There are three usual groups. And once you are doing TIFA for any reason, like routine pregnancy, or when you are doing the TIFA, heart fetal echo itself a part of TIFA. So when you suspected anything, then you have to go for the fetal echo to diagnose the any congenital heart condition. But remember, there is a catch on that. Some heart disease you may not able to detect even after that. So then even after that you have to do the neonatal screening, so that some diseases will evolve in the late trimester, late pregnancy, like coarctation. So once you get any little clue on the fetal echo, you have to follow it even up to the last trimester. You have to follow after birth, for because the coarctation such diseases will evolve over the period. Aparna, you want to add anything?
Not much, Dr. Sudeep. As you said, the common indication for fetal echo, it can be either some maternal factors or some fetal factors. So maternal factors, some infections like, let's say, history of rubella in the first trimester, or if the mother is getting some special group of medications which can potentially cause fetal anomalies. So some of them are treated for psychiatric
Seizures
issues, yeah,
or
and
epileptic medication.
yes, anti-epileptics, drugs for convulsions, drugs for psychiatric issues like tricyclic antidepressants. So this group of mothers, we need to be very, upfront and proactive doing a fetal echo. Likewise, from the baby side, if there is any non-cardiac anomaly detected in the baby, like for example, there is commonly we see the baby is having scan reports showing renal pelvic dilatation, right? So that's one of the common abnormalities that we see in a scan. So if there is one non-cardiac abnormality, it is always better to do a fetal echo because cardiac anomalies is going to contribute significantly to the morbidity and change the management later. Likewise, fetuses with diagnosed or suspected genetic issues like chromosomal problems like trisomy 21, babies who are having abnormally high heart rate or low heart rate. So we say fetal tachycardia or bradycardia. Or if you sometimes find in the scan that there is hydrops. Hydrops is a condition where we think the baby is gone into cardiac failure, so fetal cardiac failure. So you see a lot of amniotic fluid and a huge increase in the size of placenta. And even organs like liver and spleen microperi enlarge in the baby. So if the baby is having unexplained hydrops, so there are some baby-related factors and some maternal factors where one should definitely strongly consider doing the fetal echo. Again, as Dr. Sudeep said, not all problems are going to get 100% picked up in the fetal echo because of inherent limitations in the sort of image. The common things that we definitely can see are major, critical illnesses like transposition of great arteries or outflow tract obstructions. But small holes in the heart, like ventricular septal defect or atrial septal defect, as Dr. Sudeep said, it may not be seen in the fetal echo. So this will still need a reassessment after the baby is born. Another question that I had for you is, we often see this report in scans. There is a fetal echogenic cardiac focus. So, what does this mean? And do you think that's an indication for performing fetal echo?
So echogenic cardiac focus is one of the most common indication for which we got referral for the fetal echo. See, echogenic cardiac focus, if the single, it has to be seen in the light of other things. Like if your like your previous TIFA, your blood test, everything is normal, then single cardiac echogenic focus is got no importance. It just suggests you have to look for the other system to rule out trisomies like any congenital heart diseases or chromosomal problems. Or sometimes even in absence of all these also 15% of the pregnancy may present with the single echogenic focus without anything. So single echogenic focus is important, is less significant, while if it's a multiple, that suggests is the more incidence of trisomies, Down syndrome, or any other thing like that. So echogenic focus, you should not worry. You should not worry if your nuchal translucence, if your nasal blown, and if your blood test all are normal, and if there is only single echogenic focus, you should not be worried. But yes, if it's a multiple echogenic focus, this is a sign of a rhabdomyoma. Sometimes they are the small heart tumors or associated with the trisomy like Down syndrome or any trisomies for that.
I think we are losing out on your audio, Dr. Sudeep. Just maybe have a look at your. Yes, yes, it's muted.
So now it must be there because some phone was coming.
Right.
Okay. So now you want to so single echogenic focus has got no importance if the other system TIFA or your nuchal translucency or your nasal bone is normal. It just shows you have to look for the other system to detect any chromosomal abnormality. But if it's a multiple echogenic focus, it's a problem. It is suggestive of your trisomies in a kid, in a fetus. Okay, so that once the multiple echogenic focus, you have to be more careful. Single echogenic focus has got no importance if your other system considered to be normal.
In which type of congenital heart disease we should advise the mother to terminate the pregnancy, sir?
To terminate or to continue? Sorry.
They should be like to terminate.
Terminate. Okay. This is a most relevant question what we are getting whenever we are seeing the fetal echo. Okay. So there are some diseases which is known as single ventricle physiology. Single ventricle physiology means when there is out of 4 chamber, only one chamber of the heart is developed. Okay. And how So these are the chamber which is got even after birth. If you do multiple surgeries also, you may not able to salvage the baby, and it requires long-term follow-up and ultimately need to the transplant. Like Dr. Aparna already, when the left side of the heart is small, that is known as hypoplastic left heart. In the same way, when right side of the heart is small, there is known as hypoplastic right heart syndrome. When out of 4 chamber, there is only 3 chamber, like single ventricle physiology. Okay, so then once you are telling that single ventricle or right, small left heart, or out of 2 vessels, only 1 vessel is there. So then also, and there is no formation of the other vessel, like which is going to the lung is small, or which is going to the body is small, like aorta or pulmonary artery, and there is no definite vessel. Then these are the conditions which we told will give grave prognosis and will tell family to decide. Second thing, it's not the physician decision to tell whether to terminate or not. As a cardiologist, as a physician, we should always give only advice ki what is the possible treatment. Ultimately, that decision has to be taken by the parents itself. So many of the people coming with the small hole, mild wall blockage, they are very worried ki whether they want to terminate or not. So remember and listen, these are the curable conditions, and these are the totally treatable conditions like TOF, like coarctation, like VSD, like pulmonary stenosis, aortic stenosis, then we should not think of doing that extreme measure to terminate the baby. Some are like in between, like TGA, TAPVC, where you have to do the surgery, and in most of the cases it will be one-time surgery, but some may require second surgery also. So that is known as a treatable, like TGA, like TOF. Okay, but like the VSD, like ASD, like coarctation, these are the one-time treatable or like almost curable condition. So we should continue. But whenever it's come to small ventricle, hypoplastic right heart, hypoplastic left heart, or single ventricle, it's not good, because ultimately whatever times you do surgery, the outcome is not good, and ultimately they will lead to heart transplantation over 20 to 30 periods of age. So these are the conditions which is not good. So we are not giving negative counseling, but we'll tell the pros and cons of every surgeon, what is the requirement and what is the need for follow-up for the whole life. And then it's on the couple or the family to decide that.
Yeah, completely agree, Dr. Sudeep. So this is a very common query that we sometimes face. Fetuses when diagnosed with a very minor heart issue, like as you said, a small hole, like a small VSD, or a valvular mild block of one of the valves. Parents tend to sometimes get worried and come and seek advice on whether they should terminate. So, as you have rightly emphasized, you can look at this as 3 broad groups of problems. So one group of problems where the outcome is very favorable, like a small hole in the heart, such as mild to moderate VSD, or a mild valvular obstruction, like aortic stenosis, which can be generally managed with a single stage, also balloon dilatation, or sometimes 2-stage balloon dilatation, who can generally lead a good quality of life. And second group is where the baby may require a critical or an open heart surgery or an intervention soon after the baby's birth. But still, once the intervention is done and the baby gets discharged, the baby can expect a good quality of life. For example, TGA, where once arterial switch open heart surgery is done, the baby can lead a normal quality of life in the majority of the cases later after discharge. The third group is where the prognosis can be really worrisome. Conditions like hypoplastic left heart syndrome, where even after surgical correction, which itself may be challenging, the baby may have poor quality of life. In some conditions like single ventricle physiology, also the child might have significant morbidity, and there may be multiple stage surgical repairs that might be required. But this being an individual case-to-case kind of a discussion that must be done with the parents, in a vast majority of antenatally diagnosed cardiac defects, the child can still have a reasonable good quality of life, and this is something that we need to reassure the parents. Now, another relevant question is coming up next. We'll take it up.
Now, how to diagnose congenital heart disease immediately after the birth? Is there any screening test, and it is necessary to be done in all the babies, or there are only like few risk cases we have to be done?
See,
So,
this is very relevant question because, sorry Aparna, you carry on please.
No, you can finish, Dr. Sudeep. I'll speak after.
So see, this is because there is the screening of congenital heart disease program. Initially thought that we can do the pulse and echo for everything, every baby, but this is not possible to do. You diagnose any problem in fetal echo, or any mother
We are losing your audio. Um, anyway, so we often do a postnatal evaluation for any baby who has had an abnormal fetal echo or an abnormal structural evaluation antenatally, even a non-cardiac defect. So it is better to do one postnatal evaluation even if the baby is absolutely asymptomatic. The other reasons or signs and symptoms in the baby where we would get a postnatal echo or cardiac evaluation would include a baby who has abnormal cardiac signs like presence of a murmur. So if the baby is having anything beyond grade 3 of a systolic murmur is a sound that is heard from the baby's heart with a stethoscope, or if the baby has signs of cardiac failure, like if the baby is having enlargement of the heart and pictures of breathing difficulty, which we attribute or which we think are possibly because of a heart problem, then one has to do an echo. An echo is also usually done when the baby has bluish discolorization of the lips, the fingertips, and the bottom. This is a condition called as cyanosis. So, in all these conditions, it is important to get an evaluation by doing an echo. Now, again, as we said, some of the signs, I think Dr. Sudeep has joined us again. So I just told that we would be getting an echo wherever there is an antenatally diagnosed cardiac anomaly. Sometimes you may also get an echo evaluation if there are multiple non-cardiac anomalies, like in a baby with Bacterial syndrome, for example. Or we may have to do it if the baby has abnormal, physical signs like the presence of a cardiac murmur, the presence of cyanosis, which is bluish discolorization of the hands and the lips, or in the presence of congestive cardiac failure. That is a condition where the baby can have symptoms and signs of heart failure. An echo is also indicated when the baby has arrhythmias, like if the baby has abnormal heart rate rhythm. There can be abnormally fast heart rate where it might go up to more than 200 to 220 beats per minute, or the rhythm of the baby's cardiac activity on an ECG might be abnormal. So, in all these conditions, one has to do an echo.
One
Yes,
more thing
Dr.
I
Sudhir.
want to add, Aparna. Sometimes when you are treating the neonate, you are, suppose for the RDS baby, you are treating in a term which is not improving as per your expectation. So once your CCF symptoms are not improving as per your expectation, when your lung condition also is not improving as per your expectation, because so many are unbooked pregnancies, so many are come directly to your NICU. So once these things are there, also there are indication. Once, like sometimes once your RDS in a term baby you give surfactant, it's not improving, then sometime you have to suspect the TAPVC is there, you have to do the echo. So whenever what Aparna told is a heart failure is there, when there's a cyanosis is there, when there's already diagnosed in the fetal life and now you have to see the outcome, or you have to see the natural history, how it's behaving, or when there is a syndrome like Down syndrome, Wetter syndrome, or kidney associated, you have to rule out. And fifth, when the heart rate is very low, very high, or fifth, when there is an abnormal ECG, abnormal X, or abnormal saturation, abnormal pulse, abnormal BP, and last, when your clinical symptom is not improving as per your treatment, then also you have to think of any cardiac cause which is contributing to that. So thanks, Aparna, for clarifying that.
So what is VSD, and when we have to intervene to treat VSD? What is VSD,
VSD
sir?
in general for layman, everything is the hole in the heart. But hole in the heart is the general term what usual the public is using for that, but it is comprising of whole spectrum. Some are the wall block, some are actually the hole between two chambers. So one of the most common heart disease which is uh, between the lower chamber of the heart, between left ventricle and right ventricle, is the VSD. VSD knows the ventricular septal defect. Septum means the septum, the partition, defect is the defect, and ventricle is between the two ventricles. The ventricular septal defect is the most common congenital heart disease, where if it's a large, it will cause the symptoms what Aparna already told, in the form of breathing problem and the poor weight gain and the feeding problem. And then you have to detect with the echo, and then you have to treat as early as 3 to 6 months. In the same way, when VSD is small or medium size, when it's not causing much symptoms, even sometime 20 to 30% may spontaneously close over the period. So you have to wait and watch. So VSD is the ventricular septal defect, that is the hole between lower chamber. Whether it's a significant or not significant depends whether it's a large or small. When it's a large, it has to be treated between 3 to 6 months of the age, whether the symptoms are present or not. If symptoms are present in the form of feeding difficulty, breathing difficulty, poor weight gain, you have to do at the 2 to 3 months of the age. Second thing, when it's a small and it's not causing any symptoms, you have to wait and watch over the period, because there is a 20 to 30% chances of getting it closed over 1 to 2 year period. Now, to close it, there are two methods. If it's a suitable, we can do without surgery by entering through the groin and put a device. But when it's a very large, without any good margin, you have to go only with the open heart surgery. But remember, anyone got VSD, the VSD has got very good outcome. It's almost a curable disease. So VSD is ventricular septal defect. Whether it's a large or small, it depends on that. If it's a large, you have to do early treatment. When the small or medium size, you have to wait and watch and follow. If it not get closed by 2 to 4 years of age, then you have to decide it to close. Or if it's associated with any complication like wall leakage, wall block, then you have to, even if it's a small, you have to close it with the surgery. Anything you want to add, Aparna?
No, I agree, Dr. Sudeep. I think you have covered everything. I think we have a couple of other things also to discuss. One of them is, as a neonatologist, I wanted to just talk about a simple test that we can do for every baby who is born. It's called pulse oximetry screening. This is just for most of the families and parents to be aware. This is a very simple test to kind of find out whether the baby has any critical cardiac problem right at birth. So all this needs is a simple machine which is called as pulse oximeter. This is available in every hospital. So after the baby is born, minimum the baby has to cross 24 hours to undergo this test. The pulse oximeter probe is generally connected to the baby's right hand and one of the baby's feet, either the right foot or the left foot. So you all know that pulse oximeter is a machine that was used for monitoring saturations. Many of us have seen it commonly being used during COVID times. So in this simple test, if you find that the baby's saturations, are in the normal range, and for this particular test, we take a number which is more than 95% as absolutely normal. So if all limbs, both the right hand and either leg, the saturations are normal and there's nothing more to be done. If there is a difference in the saturations between the right hand and either foot, and if the difference is more than 3%, so for example, if the saturations in right hand are normal, say around 98%, but persistently in the foot it is coming low and the difference is more than 3%, this baby needs to be re-evaluated and we repeat this pulse oximetry screening. If at all the saturations in any of the limbs is coming continuously as below 90%, again, this is clearly abnormal. And then this is a simple test for us to refer the baby for an immediate echocardiographic evaluation. So either if the baby's saturations are below 90% or if they're between 91 to 95% repeatedly, and if the saturation difference between the right hand and either foot is more than 3%. So this is a very, very simple test which all centers can do, and this helps us to know in one look whether they're dealing with a critical heart problem. The only few riders with this test come as positive or abnormal even with lung issues, like when the baby has fluid in the lungs, or if there is infection in the lungs, a condition called as pneumonia, or sometimes when babies swallow meconium, a problem called meconium aspiration syndrome. These can lead to lung issues and abnormal pulse oximetry screening. So this can be easily differentiated by the pediatric doctor. And the other problem is it may sometimes not pick up some critical heart diseases like coarctation, where there is a block or an obstruction in the blood flow, or in some other problems where there is a hole in the heart like VSD. But these are all problems which still do manifest with some other symptoms later. So at least the more critical heart diseases, which may sometimes be not easily detectable just after the baby is born, we may discharge the baby and then the baby may come back with some serious signs and symptoms within the first 1 month. Those type of defects can be picked up with the pulse oximetry screening test. Any comments, Dr. Sudeep?
What you told is correct. Pulse oximeter has got positive and negatives, but the more positive, less negative first. It's a simple test where which if it's a very critical, you can able to detect very well in the initial time. Some may evolve later, but once you got there, So you have to know that if it's a critical condition, it will be get detected. It's a simple test available in periphery everywhere. And even with the pulse oximeter, if you get the tracing also you are getting. So if you get the pulse oximeter, if they are putting and you are getting a good trace, that also suggests whether the heart function is good or there is a block. So pulse oximeter is a very good tool. When it's a low saturation, you are able to get, and with it and critical conditions, you are able to detect very early. And some of the things we which get missed, but we should not tell, but we should not undermine the importance of pulse oximeter in diagnosing the major heart problem in the initial days of the life. So pulse oximeter is simple and widely available tool. So I agree with you, the Aparna, and you explained it very nicely for all the other things also. So good. So you should have pulse oximeter everyone. We have to make good use of it for the diagnosing critical heart conditions.
So can the baby with congenital heart disease lead a normal life? And what are the precautions that has to be taken?
That's a very extremely relevant question. Second, see what we told two things. Me and Aparna stressed on there are three types of defect. One is very curable, one is treatable and having near normal life, and third is the condition with a very complex heart disease which may need multiple surgeries. So in the first group where it's a completely curable, like simple hole, mild wall blockage and simple wall repair, once you close it, the baby may live a near normal life like any one individual can have. Second is treatable, like TOF, TGA. Once you do your surgery at the proper time, and if you follow properly, they have near normal life. They can do the what all near. But in some of that, 10 to 20%, you may need again one or two surgery. But the routine life, they can have very good normal life. Although some of these may not have the athletic ability, but the near normal life, like a normal person, what they are doing the office job, they can able to do. Third one with the complex heart disease, which may lead the multiple surgery. That is the group which has got the problem, which may able they may not able to do the great athletic work. They need multiple stages of surgery. So that the only group which may not able to have the normal life. But the first two groups are having near normal life. They can do. Even the third group, we have some patients which are even the athletes, have the gymnasts, and have doctors. So even there is complex heart group also. So all is not black even for that group. If the complex heart disease also operated well in a good center, you may have near normal life with a good outcome. But that is still evolving. We cannot say 100%, but we can say definitely for the group one, where it's a curable, like the simple heart wall problem, simple hole, or with the leak, where we can get the near curable disease and they have the completely normal life. Second group is around near normal life. Third group also may have the good outcome if they operate at the right time with the right center and with the right surgeon or cardiologist. They have the near normal. The third group only has got the problem, which is still some patients are coming which has got the near normal life, but they need the very meticulous follow. So two things, all is not black for congenital heart disease. They are the good outcome, but you need continuous follow up. That if some problem arises, you detected early, you treated, they have the near normal life. So the message is, don't be scared of congenital heart disease. You may have able, the child may able to have a good life, and if you do the proper follow up in a proper center, if you diagnose a problem early, you can treat early, so that have a very good quality of life. Aparna, you are the neonatologist. You saw so many babies operated by us. You share your experience also. How you saw the babies, what we operated in neonatal age now coming ages of 6 to 8 years.
Yeah, I completely agree, Dr. Sudeep, that congenital heart disease post-op or post-intervention children are one group of most, I think, rewarding and satisfying outcomes for a neonatologist. So, as a neonatologist in a unit that is catering to a significant volume of critical heart diseases, we have had the chance to manage babies who have had open heart surgeries, like for conditions like transposition of great arteries, total anomalous pulmonary venous connection, or large VSD. We've also been able to manage with the pediatric cardiologist team, Dr. Sudeep sir and Dr. Gautami ma'am. We've been able to manage some babies with critical valve obstructions like pulmonary or aortic stenosis. We've had babies who needed first intervention followed by a second open heart repair, like pulmonary atresia with VSD, where or say severe pulmonary atresia, intact septum, where we would have done first BPS stemming, and then subsequent stage correction with the open heart surgery. So all these babies, I would say, have, as Dr. Sudeep said, majority of the babies, like almost 90 to 95% of the babies, would be able to lead a good quality of life. 5 to 10% babies may have some recurring health requirements in the form of medications, frequent follow-ups. Sometimes, rarely, we may see some post-operative problems, which may result either in poor growth, or they may have episodes of gastroesophageal reflux, or cardiac issues requiring medication. But majority of the babies, this is a very, very satisfying group to treat, because once this is sorted out and the baby goes through the immediate post-op period, the baby is discharged from the unit. Majority of the babies can lead a near normal quality of life like any of us. They just need to be coming back for follow-ups when advised. So I agree, this is a very satisfying group of problems that we manage, and it is just the need for increasing awareness for earlier recognition with fetal echo, as Dr. Sudeep has said. All we need to do an echo, how we need to be prepared, and when these problems are diagnosed in pregnancy, it is always very, very, very important to plan the delivery in a tertiary care or a quaternary care setup, where the baby can be immediately managed, stabilized, and a specialized pediatric cardiology team that includes the pediatric cardiologist, cardiac thoracic surgeon, and cardiac anesthetist can immediately manage the baby's intensive care requirements. This is a very, very important point to be remembered. Often we find that babies are delivered in elsewhere, and then they are brought at a very late stage. So it is important to plan the delivery itself in a setup where the immediate access to this expertise is available, and when the right care, timely diagnosis, appropriate immediate medical management and stabilization, and timely accurate diagnosis is made, and timely surgical or cath lab intervention is undertaken, majority of these babies can lead a near normal life.
One more thing I want to add. See, there are so many babies who are coming in the diagnosed of heart disease, but somebody told the patient is not symptomatic, it is not having problem. Why your doctor is telling to go for the surgery? So you have to remember, when anybody diagnosed heart disease, listen to your cardiologist, listen to your cardiologist, listen to your doctor. Don't listen for the nearby people who are just telling you why the doctor is telling the baby is absolutely all right. The baby may be absolutely all right at that point, but once, sometimes like a whole, if you lose the critical time, in after some time when the lungs pressure becomes so high, it may not be operable. Then the only option will be heart lung transplant. So don't listen whatever the cardiologist or your neonatologist doctor is telling. This is important to operate. You have to go with that, because we are seeing so many babies when their parents are telling the patient was absolutely all right, why to go for that? And then once they become deteriorated and then they come, then we don't have any option, and then the risk also will be high, and sometimes it may not be operable at all. So what Aparna also key, when it's a correctly diagnosed, come at the correct time, so that we can give a very good outcome in the 90% of the baby to have the good and near normal life if we get operated either by the device or by a surgery at a proper time. We may I am surprised and I am very happy to share with Aparna, because in our team we did even 700-800 gram baby also. We operated with a device, and then now they are coming at the age of 2 to 3 months and doing very well. So once we operated at the right time, and once you operated even the complex heart disease, TGA, TAPVC, we saw so many babies 10 to 15 years they are having near normal life. Once we tell you it's a important to operate, just listen that and don't follow into the trap ki the child is asymptomatic, we can do when the weight is big, when we can do the when the child grows, how is it possible to in the small baby. These are the some myths ki surgery is not possible in the small baby. This is a myth. Even 700-800 gram is possible. Second myth is there ki when they grow then only will get to do that surgery. That is also not correct. Third thing, some even the complex heart problem, somebody told ki it will close by itself. So that is also don't follow. Go to your doctor, follow their advice, and once you follow correctly, you will only realize the child life is near normal. And you will be happy to see that. Aparna, anything you want to add?
No, that's all from my side. I think we've had a very positive and encouraging discussion today. I really hope that it would be useful for those of us who are listening to the session, and we are able to give better quality of life for these children who are actually capable. Majority of them are capable of leading a normal life if as families and as medical healthcare professionals, all of us can jointly resolve to pledge towards early timely screening, early diagnosis, and prompt referral and prompt management. I think we thank everyone for joining us today. My colleague Dr. Sujana was barely visible, so I would like to thank her for being a part of the program and for asking the questions. And thank you, Dr. Sudeep, as always, for being an expert, for sharing your vast experience and your suggestions on this important aspect. So thank you all, and we'll meet you next Tuesday
Thank
again
you
with an
all.
interesting. Thank you, Dr. Sudeep. So we'll meet everyone again next Tuesday at 1 o'clock with another interesting discussion with our fetal medicine expert, Dr. Chinmayi, and our clinical director of obstetrics gynecology, Dr. Shilpi ma'am, on discussion on prenatal diagnosis of birth defects. Thank you, everyone.
Thank you. Thank you all. Good.